wanted to officially welcome you to my podcast today. We're talking about palliative care. It's a topic that frequently comes up in terms of my own patients. And unfortunately, there's a lot of confusion on the part of not only patients, but sometimes the doctor about what palliative care is, how it works, how it differs from hospice. So I think this will be a great podcast to educate people in general. Tell us about yourselves and how you basically got into focusing on palliative care.
Okay, so I'm a psychotherapist and I've been in the field for over 30 years. And I've always taken an approach with my career that just say yes, because you never know where it's going to go. And so it's led me on this circuitous path to getting here. I was working in a behavioral health inpatient program and I got really bored. It was just like, if I told somebody one more time, you matter, life is worth living, I'm going to kill myself. So I switched to working in the medical side and I was doing a lot of case management. And I was transferred to the ICU and I had a patient that was in his 90s. The adopted son was having a really hard time making decisions about shifting to comfort-focused care. And I was really working with him on the importance of making decisions. Do we really want chemo and radiation and escalation of care where his heart was at high risk of stopping? So son could not make a decision. The patient ended up coding, and there's these big guys doing CPR on him, and you're hearing the ribs crack. It just felt like an assault to this guy that could have had a really peaceful death. And it just broke my heart. And I think just still hearing that and seeing that image fuels me that this is really important work and that we have a better options to die. A lot of people don't want to think about dying, but we don't really have a choice. And as the sandwich generation, as we're seeing our parents or the older folks in our lives we're having to make decisions for them, or they're making decisions about how to die. And I think our generation, that what is the option? What's the bigger picture here? And how can we remap the way we want our end years to be?
I agree with you. This is always a tough topic for me. One of my favorite patients just passed away a week ago. I believe she was 95. And my most favorite patient is currently still alive, and she's 103 at this point. But when it comes to end of life and advanced directives, it is a topic that I always talk about with patients, whether they're 25 or they're 95, because it's really important to know what your wishes are, what you would like us to do or not do. And that may include everything. But what I often find, Anne, is that even when I go through all of that, sometimes it amounts to not having any effect at all, because something dramatic happens. And I'm like, I thought we decided that we wouldn't be doing all these things. So do you find that with your patients?
Yes, it's really hard because as you're in a medical crisis, it's like, I don't know a lot about biology, but it's like we have this natural want to be alive. Maybe it's a survival instinct. And so when somebody says you're having a harder time breathing or you're needing more medical support, what do you want to do? I think the natural inclination is, I don't want to die. I don't want to give up. I still want to be here. And so all of the planning for the future just gets thrown out the window. I think this is where we could talk about how palliative care can be really helpful, because you're building that relationship over time, particularly in the outpatient setting. But also, I think when you're in those critical situations, like as the primary physician, setting all those things up. But in the moment when the person's dying, you're having specialists say, do you want this or do you want that? And the kidney doctor says, your kidneys look great. You're going to be living a long life. And the heart guy is saying, this isn't looking so good, but we could try A, B, and C. And people tend to grab on to the positive news, not really looking at the whole body. And that's where I think palliative care can be important. But also just the language. I mean, a lot of it's the patient and the family and just unpacking that stuff, that why are we clinging into life when, the person is so sick? But for the providers, the healthcare, it's really making sure our language is clear. Do you want everything, or what do you want? Everything could mean transferring from the hospital to home with hospice, where you're getting care and support and your family can be there. Or it could mean going up to the ICU and getting on machines and things. And people don't always play out the scene. I have a patient right now that I see in the nursing home, and every time I see him, it breaks my heart because he wanted everything when he was in a critical state. He ended up having a stroke, and now he's on a permanent tracheostomy. It's like, this is what life looks like. Family may have come every day or every week, and now the visits get slower. And I don't know, that's not quality of life to me. But when we say, do you want to do everything? It's assumed yes, because I'm going to get back to being the person I was yesterday. And that's most of the time not the case.
Unfortunately, you're right. Maybe you can educate my listeners, because I think I see this a lot in terms of patients where when you bring up the words palliative care versus hospice care, they don't necessarily understand the difference. And often when you use whichever words interchangeably, they often think you're basically saying that everything will come to a stop, that nothing will be done for them. So can you educate us about what palliative care is and how it differs from hospice care?
Yeah, when I was working in the ICU, we had the difficult discussions in a conference room. And so I had a patient that was like, I'm not going in there. I'm not going in there. And it was this idea that if we talk about goals and what's important to you, that this means we're giving up and this means you're dying, whether or not the doctor's saying you have that prognosis. You guys are keeping stuff from me, and that's what's really happening. So it is important to have a definition of what palliative care is beyond what end-of-life care is. And if you think of palliative care as overarching, we're working from initial diagnosis straight through to end of life. And hospice is a small part of palliative care, but palliative care is that whole spectrum. So a lot of my patients are coming in newly diagnosed with a serious illness. We say that you have to have a life-limiting or life-altering diagnosis. So, for example, cancer is a life-limiting disease, but with all of the interventions, you can live with cancer for 20, 30, 40 years, or you may not even die of cancer. But just to qualify it, it is a very serious disease that has a trajectory. So a lot of my patients are newly diagnosed, sometimes going through chemo or radiation and having symptom burden, whether it's the physical part of the chemotherapy or nausea, a lot of pain, or if there's the psychological part. It's just very emotional. And I'm a cancer patient. My husband has metastatic cancer, and it's just been a hugely emotional journey. Some parts are traumatic, just being poked and prodded and worried about your lifespan. So there's that whole emotional and existential part, and getting palliative care early on can help address some of that distress. And as the cancer or the serious illness progresses, like with my husband, he's non-curative now. It's in his lungs, it's in some of his bones. So we are having to revisit, yes, you probably have a long life. Yes, there's a lot of interventions, but let's start preparing ahead of time so we don't have to make those rush decisions. And it also helps families in the end because we've had those conversations. We have that relationship with the patient and the family so that we can say, let's go back to what we talked about a year or two ago. Let's go back to who you were 20 years ago and what was important to you. And now we're in this critical thing where we say, yes, I want to do everything, but let's go back to that logical piece. And that's where developing the relationship with the palliative care team is so important, because we can get you back. Let's look at that whole picture, not this critical event.
So I'm sorry to hear that about your husband. And you mentioned that you also have cancer?
So he was diagnosed in 2019, and then 2020 hit when COVID wrecked our world. And then I was diagnosed in 2021 when the world was opening back up. I have a stage 1 breast cancer. So I had radiation, I had surgery, and I'm in, we call it no evidence of disease or in remission. So mine is wrapped up other than medication. But it's been an interesting journey because I'm working with cancer. I've been through it, and then really seeing my husband through more of a palliative care case. With palliative care, oftentimes we work with new diagnosis. A lot of people stay with us in the middle course of the disease because you're dealing with the physical symptoms, you're dealing with planning for the future and the emotional and the spiritual part of it.
Can you describe what your own experience has been, as long as you feel comfortable, obviously, in terms of palliative care? Has it been like a group of people that have helped you so my listeners understand? Because a lot of people get confused and they think I'm just writing them a script of sending them to their deathbed when I'm not.
Right.
So can you share that experience? What kind of people have you worked with under that palliative care umbrella?
Yeah, and that's where we get that all the time. And the importance, I think, for your listeners, if you have a question, just get more education. Just talk to a palliative care program. You're not going to get jinxed. It's not going to mean that, the universe is going to go against you, but just really trying to understand. But with my palliative care patients, basically, we're an extra resource. We don't replace any of the other physicians. We're just an adjunct to that. I don't know the Latin word, but basically the word means to cloak, to provide that extra support. So when we're coming in, we're like, let's treat you as a person, not as a patient. Because if most of the times when you have a physician visit, you're coming in for 15 or 20 minutes, you're very focused on the physical. You're out the door, you get in the car, you have a bunch of questions you forgot to ask. Palliative care is, whoa, let's step back. Who are you as a person? What do you do for a living? What's your family like? What's important to you? What are your priorities? What are your hobbies? And as we get to know you as a person, it starts to make sense what the treatment options are for you. So if you're 95 and you maybe love your garden and want to be at home, palliative care can talk about this is the advantage of hospice, maybe, or this is the advantage of not going back and forth to the hospital. If you're in your 40s or 50s and you're working and you have high productivity, you're taking care of your kids, you're probably going to want pretty aggressive interventions because there's a good likelihood of getting either back to where you were or to at least to be able to do things that are important to you. So palliative care, the first part is really getting to know you as a person. And then based on that, what is quality of life to you? And that's different for everybody. A lot of my patients they come in with pain or high anxiety and sometimes other symptoms like bowel issues or nausea or things. So sometimes the first priority is let's get you physically feeling better. And the palliative care physicians or nurse practitioners are specialists just in symptom management. They're not going to prescribe radiation or prescribe cardiac rehab. They're just simply there to say, how are you feeling and how can we medically address so that the one doctor is not giving a set of medication, the other is giving a different, like how are they interacting? What is right for you? So managing that. And then once we get the physical part, oftentimes the emotional part comes down. I had a patient just last week that was all physical. And the chaplain and I were also in the room and we're just sitting back like, we don't know what's going on. We don't know what they're talking about. And he physically was just talking about all this nausea and pain. So then the doctor and the nurse did their part and the chaplain and I start talking like, how are you feeling? Like, how is this making sense to you? So then all of us had a discussion about, wow, we didn't know you did that for a living, or we didn't know your kids were nearby or whatever. Started having this conversation. And at the end of the session, he was like, it's so weird. I don't feel nauseous anymore. Like my pain feels better. And it was like being treated as a human, feeling listened to and heard and seen. To me, that's better medicine than anything that we can do in terms of prescriptions and things. So that's palliative care. We slow it down. We try to get to know you as a person and then find out what your goals are, what your values are. So we can say in the lens that we know your illness is going to progress. Let's plan for this so we don't lose the humanity in the process.
The nature of your practice, do you work independently? Do you work with a group or a hospital system? I'm just trying to understand how you function. And then also educate us, what kind of specialists would you be seeing in a palliative care team?
So palliative care exists across settings. So in the beginning stages of palliative care, it was a lot of inpatient medical, making critical decisions. And then it really evolved to my team. We're outpatient. So you would get a physician and physician order, and then you would see us the first visits like for an hour. And then we do monthly follow-ups for a half hour. Sometimes our patients are getting more and more sick and it's hard to get out of the home. They're needing more eyes on. So then in-home palliative care becomes an option. So it's various settings. And then there is palliative care in nursing homes too. My team in the outpatient setting, we have a physician, we have a director who's a nurse practitioner. I'm a social worker, therapist. We have a chaplain on the team and a nurse. And so we all have our own specialties. The nurse and the doctor are the physical. I'm more of the emotional. The chaplain is spiritual and existential. But we overlap because if we're going to have 4 different meetings, different things are going to come up and they don't always connect. But like with the patient with nausea and pain, I'm guessing he had some anxiety about meeting with us, meeting with this 4 people on a team. One minute we're talking about pain, the next minute we're talking about anxiety or depression. And then we're going into, I feel punished by God that this is happening to me, or how do I make meaning because I feel like my life has changed because of this? So it's like these wormholes that are constantly talk about one thing, we get to somewhere else. And then as things come up in a more natural conversational flow, then you get to the bottom of it. Like people won't even know what to ask or what to say. But then there's certain clues that we'll say, oh, okay, maybe this is the issue. And then we can present it and cross work together on that. So all of us have our specialties within that group, but we also have training so that we overlap. So if the nurse isn't there, I have enough knowledge to say, okay, this sounds medical. Let me get the physician, the nurse involved. Or if it's emotional, like trouble caregiving burnout or trouble accessing resources, okay, let's move that to them. But there's a basic knowledge. Some of the teams in larger groups and things have palliative medicine, not necessarily the social worker or the chaplain involved. And so sometimes people get a referral to palliative medicine, and it's important to ask, are there other resources like either embedded in the team, the social work and the chaplain, or at least have some adjunct resources outside of that group?
So we've talked a lot about palliative care. Educate us as to what hospice care is.
So hospice is a service that really you're bringing the medical piece into your home. A lot of people think that hospice is a place that you go to. In some states, in some places, there's hospice homes that you can pay for, usually privately. But generally, hospice comes to you wherever you're at, if you're in a nursing home, if you're in assisted living, or you're in your own home. So hospice is generally prescribed based on Medicare guidelines as having a prognosis of 6 months or less. I have patients that have been on hospice for a couple of years or even longer. But generally, if we say the patient has a prognosis, if they had no curative focused treatment, it wouldn't be surprising that they would be at the end of life in the next 6 months. Hospice comes in where, like palliative care, you have a physician, you have nurse practitioner, social worker, chaplain, nurse, and they come in and provide the care. They also provide, it's a bundled rate. Hospice comes in as a bundled rate, so they provide everything. So you have a crisis in the middle of the night, you don't go to the hospital, the nurse comes to you within an hour or so. They provide all your medications, they provide equipment like a commode or hospital bed or things, so that the goal is to keep you as comfortable as possible in the home. This is a really helpful benefit for people that are really like, I'm just going to the hospital all the time, or I'm having a hard time getting out of bed, but I need to go to all these specialists, and it's not changing. I'm still on a trajectory where I'm at the last chapter of my life. So how can I have the best quality without trying to chase things that aren't going to be cured? So it's an excellent benefit. And my frustration, and probably yours, is that people don't allow for hospice until it's so late that they are in the dying process, because I don't want hospice. It means I'm giving up. It means I'm going to die. And so people wait to get on hospice, and then they die within 7 to 14 days. Every time I have a patient that starts sooner when hospice is recommended, they say, I wish I would have done this sooner. This is what I want. This is what's meaningful to me. And then that's where we're making the right decisions to have a peaceful death for that person, rather than like my patient I discussed before, where you're in the ICU and escalating care that probably they didn't really want.
Thank you so much for sharing that, because I think that will actually help people understand the difference, and also practitioners, because I think that there's confusion amongst people who see patients about what the difference is and when it can be useful for people. Obviously, the palliative care provides a holistic approach for patients. I think when I was a young resident versus now, I think the priorities of, not the priorities, different word, the goal, if you want to use that word. Initially, it was to save as many people as I could. And as I got older, I realized, okay, first, obviously those words do no harm definitely come more into play. And then secondly, I'm always about making sure that people are their healthiest and happiest. And my goal is not always to make you live the longest that you can. If that happens and you also stay healthy and happy, that's awesome, as we're not always in command of how that goes. The other difference that I see is that the cultural aspect is that I think in America, I think, how do I say this? I think even amongst people, we as a society, I think that there's like this belief that we're invincible and
Yeah.
that nothing will happen to us. Whereas I think on a more Eastern, if you subscribe to this, you realize that we're not invincible. There's a finite aspect to everything. And I straddle both of those things and I try to incorporate both of that with my patients, but it's often very difficult. So, how do you teach doctors such as myself about how to effectively communicate with patients when it comes to these difficult conversations that we often need to have with people?
I think it goes back to helping people or doctors to get in touch with their humanity. There's studies that show that what the doctors prescribe to another patient, that I would go to the ICU, I would do all these things. If you ask them what they would do for themselves if they were in that situation, they would say, no, I don't want all that. Putting yourself in the other person's shoes, looking at the bigger story, and what does that come up for me as a professional, that I am not able to fix everything, that I am not able to be that superhero. Not that I think most doctors go in that way, but there's just you're trained to heal, you're trained to fix things. And when you can't, sometimes physicians feel that's something on them, that they didn't do enough. And I think the other part is it's just really hard to sit and be in the room. And I see this when I work with the doctor and the nurse. I'll see a patient crying or really emoting and being scared, and the doctor and nurse are, let's do this, let's give medication, let's do something. And sometimes something is sitting back and just holding a hand or just letting the person cry and not feel like you have to fix it. And so helping, I guess, doctors go to that softer place, that it's okay. And I have our doctor even gets frustrated sometimes, and I feel like I'm just sitting there not doing anything, and it's okay. Maybe the patient just needs to be heard. And that's where sort of the social work, the therapist, the chaplain part comes in, because we are talking more what you're saying, that it's a life cycle and not everything is going to be, there's not a pill for everything. So let's step back and just be with the person. And oftentimes patients know how their illness is going. They know what's ahead. They might be scared. They might not want to talk about it, but there's this weird codependence between the physician and the patient. I don't want to tell you that I know my illness is getting worse and that I'm probably dying, because I don't want to disappoint you, the doctor, who's invested so much time and energy on me. And then the doctor's saying, I don't want to tell you that this isn't going well because I don't want you to lose hope, or I don't want you to be sad. And a lot of times, I can't speak for you, but a lot of the doctors I work with they have a hard time with the emotions. It's when the emotions get soft, it's, ooh, I wasn't trained to do that stuff. Let's go back to science. Let's go back to the hard knocks.
I'm more used to it, I should say, because I realize that I can't make everyone live forever, nor do I want to. But I still feel that I've failed. It's almost this feeling of failure that I'm like, okay, but this person, and then the other side of me is, okay, that person was 95 years old. 99
Right.
years old. What were you trying to do there? Not that I was actually trying to make them live longer than that, but it's very difficult. And often they're family members, even if they're not my patients, often they are.
You see it in their eyes, and it's like, how do I look at them with the compassion and still telling the truth? It's really hard. I think it's about saving their dignity and their grace in their life cycle, because we can't fix everything. And if we're talking about saving to the nth degree, when a person, if they knew better, they may not make those choices. It's really about how can we preserve the humanity so that people, whatever the course of illness is, they're feeling like human beings and not just a science experiment.
Yeah. I don't, and I'm thankful for it because I don't think it's meant for me to see, but it often sometimes comes up like, is this how you want to remember your parent or your loved one? Is this
Yeah.
how, let's say that person can't make those decisions anymore. Is this something that you want to continue? And have you ever had conversations with them as to what they would or wouldn't want? Sometimes even in the aftermath, you're still having those kind of discussions with family members. I often see multiple generations of people in a family. I'm still having those conversations, even though I'm not in the hospital, because I'm taking care of that person's son or daughter or even
Right.
grandchildren.
You're probably the one that they trust the most because you've had that relationship. Trusting your outpatient doctor is really an essential part because you're the sort of the neutral person. But then I think for doctors also, like when you're describing these really complex relationships and intergenerational, there's grief, I think, for the doctors too, that
Oh, yeah.
I don't want to lose this person. With my patients, we've seen patients for years and it's, oh, that hurts. That one hurts. And you move on, but it's allowing space for yourself too, that it's okay that we have feelings
Yeah.
about it. It's just human. We should be connecting on that level with people. That's what good care is.
In New Jersey, we do have medically assisted suicide.
Yeah.
So I do have one patient, and she ultimately decided not to do it. But when I got a letter saying that this was the step that she was going to take, I was the one who was like, oh no, don't do it.
Yeah.
Not knowing anything. But yeah, I was like, please don't do that.
Like, you're my baby. It's hard. It's really hard. But I think it's such a complicated relationship because you're holding bodies to put them together to live longer. But then you're also holding the hearts that these are people. Like, these people like wedge into your heart where they matter. And so it's a lot of responsibility that doctors have. And it makes sense to me that sometimes it's really hard to have those complex discussions because we don't want to be the ones.
We don't, but it's a burden that comes, if you want to call it a burden, it's a responsibility
Yeah.
that we have to make sure that if we can give a person the best end of life, then that's a responsibility that we should take. It's not a
Yeah.
burden because we are not always lucky enough to have that. But if we can provide that for someone, that's actually a privilege and an honor. And so when there are times when I know that, okay, my patient who I've known for God knows how long, and they passed away peacefully and they lived the best life that they can, it's an honor to be able to say, okay, I was a part of that.
It really is.
Yeah.
Yeah. Then also knowing, and I find this with palliative care too, obviously we're dealing with a lot of complexities, but really holding space for ourselves and each other, that this is hard work that we're doing. And I think for most of us, for me, it's a calling. This is what gives me meaning, but it doesn't mean that I'm not human and that the accumulation of patients and special ones that they're not going to hit me, they are. And so how do I take care of myself so I can maintain that objectivity? It weighs on you if you don't provide yourself the compassion and space to let those feelings out.
Of course. And I think for those of us who deal a lot, and I think that includes primary care physicians, oncologists, there's certain specialties where we're frequently seeing this and dealing with patients who are closer to the end of life. I think it's important that we have professional care ourselves, where we have an outlet where we can talk to someone objectively and in a safe space where we can let out our emotions and be safe. So we've learned a lot from you, Anne. And honestly, I think this will be a great listen for anyone who wants to learn about palliative care and hospice care and how we can really help people. What haven't we talked about that you would like to include in the podcast?
I think the only thing I would say is that even as much as we've talked about it, there's just so much confusion and just being okay to ask questions I'm on TikTok. So a lot of times I'm like, there's so much information on there or on YouTube or social media just to get like put the questions out there and see, but then also talking to professionals that it doesn't hurt you to call a hospice company or to call a palliative care and just say, I don't really know if this is helpful to me, but just wanted to get more information. And if you, for instance, called me and said, I don't really know, and I say, you seem like you don't need palliative care, I have enough experience to know what maybe you need chronic pain, or maybe you need some other avenue. We have a lot of experience, and the doctors have a lot of experience to know where to plug you in. So just not being afraid to take the risk. And especially we're talking about palliative care, how much of a support it is, that just don't be worried about the semantics of it. Just go in with an open mind.
My listeners did want to find you on TikTok or Instagram or on your website. Where should they go to get that information?
My website is www.annefront.com. So annefront.com. And then the TikTok is the Palliative Therapist. So you can find me there. I started the TikTok because I keep answering the same questions over and over again. And it tells me there's so much information that's wanted, but it's not out there. Whatever you can do to educate, ask the questions. There's a lot of help out there. And with serious illness, people feel so isolated and alone. That breaks my heart. I would rather connect people so that you feel like we're all in this together.
Thank you so much for joining us today.
Thank you for having me.
Yes, this is a great topic, and I think it really will help a lot of people in terms of understanding what palliative care is and how important it is to healthcare.
Thank you for all you do. You're on the front lines. So I really appreciate all the work you do.
Honestly, I enjoyed talking to you so much. So you're always welcome to come back and
Thank you.
we can talk more. Yet this will be available on Apple Podcasts as well as YouTube.
Thank you for your time. It was really nice to have this discussion.
Yeah.